Hello, everyone. This is the lecture on drugs for asthma and chronic obstructive pulmonary disease, COPD. So I would recommend that you refer to the lecture from the last Pathoform course from last spring, which includes the content and PowerPoint slides and lecture on the chapter 39, which is which precedes this chapter about the anatomy and physiology and the pathophysiology of the respiratory system, at the pulmonary system and the lungs and the bronchioles and all the details about the EMP and the pathophysiology of the pulmonary system. So this will be specific. I mean, this lecture will be more focusing on the patients with asthma, what drugs are going to stop the episode, which is the acute episode, or for maintenance and trying to eliminate or reduce actually the number of episodes the patient may experience, which is the frequency of episodes and the acute attacks of asthma, and also the medications for patients with COPD. So the first slide talks about or explains the anatomy and physiology of the lower respiratory tract, in which the bronchioles, which is a very important concept here, is that the bronchioles, it's a muscular elastic structure, which means that there is a potential for this smooth muscle to relax and contract, and that results in the increasing or decreasing the diameter of the bronchioles. So either the patient will have a bronchoconstriction or bronchodilation. And also in Pathoform 1, we discussed the concept of the respiration as a process in which there is an exchange of between the alveoli, air and the alveoli, and the gases in the both alveoli and the blood vessels. But blood vessels, the capillaries of the lungs, and in which that exchange of O2 and CO2, it's governed by the VQ, which is ventilation perfusion ratio. And we said that in the ventilation, which is the oxygen content in air, which enters the bronchioles and then in trachea, bronchioles, and then into the alveoli, and the perfusion, which is the blood supply to the capillaries of blood vessels surrounding these alveoli, and that exchange between these. So we need a good ventilation, good perfusion for that process to take place, which means results in a VQ ratio. And if you refer to the class from Pathoform 1, we have an extensive discussion on that, in which conditions that will result in decreasing or increasing that VQ ratio, and what that number means, or each number means, in which that we said there is a dead space and the physiologic dead space, and that is included in the discussion from Pathoform 1. This slide explains again, the same concept, which is the structure of the bronchioles and alveoli. The bronchioles, how it's the decreased lumen or size of the bronchioles will result in bronchoconstriction. That's due to two factors. The first one is the inflammation, in which that the inflammatory cells or the inflammation is going to decrease the lumen size. Same thing where there's a bronchoconstriction, in which that the smooth muscle will contract and result in decreasing the lumen size of the bronchioles. So the inflammation, that's due to the edema of the mucous membranes of the inner linings of the bronchioles, or due to bronchoconstriction due to the smooth muscle contraction So both factors will result in significant bronchoconstriction. There are two different types of lung disease. One is obstructive, and the other one is called restrictive lung disease. Examples here. This slide shows um, some of the obstructive lung disease, like bronchiectasis, and like patients with cystic fibrosis or asthma or emphysema, like COPD, or bronchitis, which is a chronic type. And when we say COPD includes both chronic bronchitis and emphysema. Both will be um, uh, labeled or classified under um, the COPD. But a restrictive lung disease that includes like patients with myasthenia gravis or with pneumonia or with the pulmonary edema. These are kind of types of restrictive lung disease. Now, moving on to asthma and the asthma, which is the chronic disease. Patient with this chronic disease, they live to different phases of the disease process, in which at some point they will have remission, and the signs and symptoms are going to be either almost absent or disappear, or patient fairly live normal life with no lung problems or like breathing issues. And at some point, patient will develop the exacerbation attack. So remission, no symptoms. Exacerbation, that's when there is the signs and symptoms are extremely high or heightened, and that will result in the patient to seek medical attention. Now, the disease, it's a chronic disease, and it's due to the inflammation, and that inflammation causes various degrees of obstruction in the airways. And all of these I have included here, that the the prevalence of the disease is high among African Americans, and that's and in addition to the high morbidity among African Americans, and that's due to many factors: underdiagnoses and inappropriate therapy, limited access to healthcare. You can include also other factors like the inaccurate assessment of severity of the cases, the delay in seeking help or assistance, inadequate medical treatment, inadequacy of the medical treatment. The also the patients, there is a high um, rate of non-adherence to prescribed regimen or therapy. In addition, also the a lot, this factor applies to almost like all ethnic groups, which is the increased allergens in the environment. Now, the asthma, in terms of the prevalence and number and statistics, this slide provides all the statistics about nationwide and globally about the severity of the significance of the asthma disease, in which that the asthma increases the burden on the healthcare system, and extremely high extent. The number of people with asthma also continue to grow, and as we said, that there is an increasing number of allergens in the in the atmosphere and the environment. Every year we hear about triggers for the asthma, and we'll talk about these triggers in a minute, about the difference between the different types of triggers or factors that would trigger the asthma attack. So, in terms of etiology and the causes, or etiology and what causes asthma, or what are the underlying causes for asthma, there is a genetic predisposition. The research on GWAS, which is the Genome-Wide Association Studies, they indicated and they identified more than 50 gene variations that are responsible for the asthma. disease. Now, the etiology, um, there are different types based on how attacks are triggered, and we are going to highlight and identify some of these triggering factors. So when we say allergens, they are the factors that will exaggerate the immune system and that will result in the production of the IgE, and the IgE response will follow. So the allergic reaction, which is basically based on the IgE response, it can be caused by, or I mean, like the triggering factors under this would be like the pollens, mold, animal dander, the dust mites. Too many factors to to identify or to highlight, and we will include some of these factors in the other slide. Now, the exercise as the triggering factor, it's characterized by bronchospasm, shortness of breath, cough, and wheezing. So when the patient, when they with asthma, when they exercise in cold, dry climates, they breathe. So if they apply or they place some kind of scarf or mask, and they can breathe through the scarf or the mask, that may decrease the likelihood of the symptoms. So it may allay some of these symptoms if they want to apply or put some kind of scarf or mask to cover the uh, mouth, nose and mouth. Now, the infections also, they may precipitate the asthma attack. The inflammation will increase the hyperresponsiveness of the bronchial tree. Some of the causes and the sources as a triggering factor for the asthma attacks, as common triggers for the asthma. This slide highlight some of these triggering factors like the nose and sinus problems. The large polyps are when they are removed for the asthma patient, we can to some extent that we can have good control on the frequency of the asthmatic attacks if these large polyps are removed or surgically excised or removed surgically. Um, the sinus problems are usually related to the inflammation of the mucous membranes. The asthma triad, which is nasal polyps, asthma, and the sensitivity to some patients have sensitivity to like aspirin and NSAIDs, so they will have like wheezing, and that wheeze will develop in about like 2 hours since from the ingestion of the these medications. Um, Salicylic acid or salicylates, um, like the because it inhibits the adrenergic stimulation of the bronchioles, and the ACE inhibitors, the it produces cough and make asthma symptoms more worse. The drug additives also can be another triggering factor, and these food additives may interfere with the prostaglandin metabolic pathways. So the reaction to these factors or to this specific factor, it may take place within like 15 minutes up to 3 hours. And it will be marked by rhinorrhea, like runny nose, nausea, vomiting, intestinal cramps, and diarrhea. GERD disease is another triggering factor. However, that the exact mechanism is unknown. But the primarily involved in nocturnal asthma. So when patients develop the asthmatic attack, that's and due to the GERD, that usually takes place during the nighttime, nocturnal asthma. Emotional stress, that psychological factors can worsen or ameliorate the disease process. So any trigger can produce panic or anxiety, which are unexpected during the attack. Now, the pathophysiology of asthma, the asthma occurs when potent mediators of the immune and inflammatory responses are released by mast cells. And this is the process we've been discussing or was covered repeatedly in different sections or different chapters, and especially under the immune system chapter, in which these on some of these mediators are which will cause the inflammation. So the resultant inflammation increases in airway edema with increased mucus secretions, and these secretions will, with the edema and the secretions that will, which will make this airways very narrow, it will comprise the process of respiration. So compromise the process of respiration and make it very difficult and contribute to the airway obstruction. Now, the symptoms of asthma result from a combination of both the inflammation and the bronchoconstriction. So the treatment must address both components, the inflammation and the bronchoconstriction. So traditionally, asthma has been characterized by bronchospasm. The pathophysiologic changes are almost also primarily due to the inflammation. So as we have mentioned earlier, is that the pathophysiology of asthma include both changes or two different types of pathophysiological changes. The first one is the bronchospasm, and the other one associated with the inflammation of the airways. Now, in terms of early phase and late phase response, um, the early phase response is triggered when the immunoglobulin type E receptors on the mast cells were become activated. So they will release the inflammatory mediators like the histamine, bradykinin, leukotrienes, prostaglandins, chemotactic factors, cytokines. All of these are inflammatory mediators that will be released from the activation of that process of the IgE receptor activation in the mast cells. So the mediators will cause significant changes, pathophysiological changes like bronchial smooth muscle constriction, which result in bronchoconstriction, increased vasodilation and permeability, epithelial damage, and increase of mucus secretions, edema, increased amount of sputum. The patient experience, so the patient during the asthmatic attack, they experience the wheezing, cough, chest tightness, dyspnea, shortness of breath. The late phase response. This late response or phase response is characterized primarily by severe inflammation. So the histamine and other mediators, they will increase airway reactivity that will result in hyperresponsiveness to allergens and other stimuli. Now, increased airway resistance leads to air trapping in the alveoli. The increased airway resistance that will lead to the air being trapped in the alveoli and hyperinflation of the lungs. And that's why you will find that in patients with especially chronic asthma or COPD, they will have this type of due to this hyperinflation of the lungs that they have like a battle chest, and we'll talk about this more in COP under the COPD. So if this airway inflammation, if the airway inflammation is not treated or doesn't resolve, that may lead to irreversible lung damage. This slide shows the difference between the three different types of lung problems. The like B, the emphysema, which is a form of type of COPD. C, which is the chronic bronchitis. Chronic bronchitis, also another type of COPD. And then D, which is the bronchial asthma. Clinical manifestations of asthma, um, unpredictable and variable. It's very individualized when it comes to signs and symptoms or manifestations of asthma. The recurrent episodes of wheezing, breathlessness, cough, tight chest, or chest tightness. Um, expiration may be prolonged, like the inspiration, expiration. The inspiration to expiration ratio might be like 1 to 2, or 1 to 3, or 1 to 4. In terms of the time it takes for the inspiration compared to the expiration time. Inspiration time to expiration time. Inspiration is shorter. I mean, the expiration is way takes longer than the inspiration in terms of time. So if we look at the ratio of inspiration to expiration, it will be like 1 to 2, or can go up to 1 to 4. Now, the wheezing is it's unreliable sign to gauge the severity of attack. Severe attacks can have no audible wheezes due to the reduction in the airway, in terms of the airflow of the airway. So severe attacks can have no audible wheezes due to reduction in the airflow. Silent chest. So we have something called silent chest. So let's first talk about the difficulty with air movement that can create a feeling of suffocation. Patients feel at some point, because of that severe chest tightness and shortness of breath, as if they are, being as if they are suffocating. So the difficulty with air movement can create a feeling of suffocation. Now, patient may feel increasingly anxious because of that. So the anxiety level will be heightened. And it will be very difficult to mobilize secretions. This become very difficult action for the patient to mobilize their secretions. So they will be blocking the airway and cause more and add more factors to obstruct the airway. Now, silent chest. Um, if the patient has been wheezing and then there is an absence of wheeze, that is called silent chest. Patient is obviously struggling, and that is a life-threatening situation that may need to require a mechanical ventilation. The examination of the patient undergoing acute attack usually reveals sign of hypoxemia. And these signs will include the restlessness, increased anxiety, inappropriate behavior, increased pulse and blood pressure. Status asthmaticus, which is fear, prolonged acute attack, and life-threatening attack, refractory to usual treatment for patients poses risk for respiratory failure, which means that the refractory to usual to treatment means that we have tried and we attempted all different therapeutic modalities to stop the attack, but that's with no positive response. that is refractory to usual treatment. We have tried to treat the episode with usual medications, but it's became like refractory. So it's a severe, prolonged attack, asthmatic attack that is refractory to usual therapeutic regimen. It's an emergency situation in which the asthma is unresponsive to the drug therapy, and that may lead to respiratory failure. There are few causes or etiologies of why the patient developed the asthmatic attack, status asthmaticus. So causes of status asthmaticus can be due to the patient is experiencing or having some viral infections. So viral illness or infection is one of the factors, or um, patient in um, ingesting or consuming large amount of aspirin or NSAIDs, can be environmental pollens or allergen exposure to allergens, or if the patient takes or being on certain um, breathing treatment, and then the abrupt discontinuation of the drug therapy could result in status asthmaticus. So, or the other, you know, um, uh, another factor, which is the abuse of the aerosol medication. So, abrupt discontinuation of the drug therapy or the abuse of that therapy could result in the status asthmaticus. The static asthmaticus is it's a um, life-threatening because it may lead to or result in the more detrimental and more um, fatal diseases or dangerous health conditions like pneumothorax or pulmonal, and sometimes death is usually a result of if the patient develop respiratory arrest or cardiac failure. So, um, and the drugs to treat the status asthmaticus would be um, first we try to prevent the asthmatic attacks, and then we have to terminate the attack that is in progress. The goal of asthma pharmacotherapy that we have to terminate the acute bronchospasm and then reducing the frequency of these attacks, asthmatic attacks. So we have a protocol here or guidelines set by or provided by the National Asthma Education and Prevention Program, in which that they provide a stepwise approach to asthma control based on the frequency and the severity of the symptoms. So as patient symptoms worsen, then the pharmacotherapy is adjusted accordingly by going to the next step. This provides for a national evidence-based approach to asthma management. And we have three general categories in which that the first category we incorporate like 4 components of care, like medications, patient education, environmental control measures, and management of comorbidities. And the next strategy is to initiate treatment based on asthma severity. And the third one is to adjust the treatment based on asthma control. So as acute asthma episode, we will provide oxygen should be started and monitored with pulse ox, or according to APGs, which is in severe cases, we will, we'll have ABGs. And we have an inhaled beta adrenergic agonist, either short-acting or long-acting. That's usually by metered dose using the spacer or nebulizer. Corticosteroids indicated if initial response is insufficient. Therapy should continue until the patient is breathing comfortably, wheezing has stopped or disappeared, pulmonary function study results are near baseline values. So going back to the slide, which is provide a protocol for treating patients with asthma. The asthma, we said, it has both bronchoconstriction component and inflammation component. So the goal of the therapy are twofold: is to terminate acute bronchospasm in progress, which is a quick relief medication, and to reduce the frequency of the asthma attacks, which is a long-acting medications. Quick relief medications, which like beta-2 adrenergic agonist, anticholinergics, systemic corticosteroids, long-acting medications, inhaled corticosteroids, mast cell stabilizers, leukotriene modifiers, long-acting beta-2 adrenergic agonists, methylxanthines, and immunomodulators. So the administration by inhalation, that's the common route of the administration of pulmonary drugs. Rapid, efficient, rich blood supply allows for quick absorption and onset of action, and it delivers drugs directly to sites of action. Inhalation is the common route to administration for pulmonary drugs because it delivers the medications directly to their sites of action. Aerosol therapy, which is a suspension of liquid droplets or fine solid particles suspended in gas. That's aerosol therapy, or how would you define it? As a suspension of small, tiny, minute liquid droplets or fine solid particles suspended in a gas. So the side effects are reduced. Systemic effects can still occur. These are the three advantages to inhalation therapy. Therapeutic effects are enhanced because they deliver the drug directly to the site of action. The systemic effects are minimized. The required small dosage of aerosol minimizes any system effects that might result from absorption across pulmonary capillaries when compared to tablets like PO medications, oral medications. So the required small dosage of the aerosol minimize any systemic or any system effects that might result from the absorption of across the pulmonary capillaries when it's compared to the PO or oral medications. And the relief of acute attack is very quick and rapid. Disadvantage of aerosol therapy, difficult to measure precise dose, usually about 10, max of 50% of the drug is placed. Instruction may be complicated for some patients. Side effects occur if patients swallow the drug or does not rinse them out after inhalation. Now, this drug provided a comparison between the MDI nebulizer and the DPI. Okay, so this is first question. Which are the advantages of DPI over MDI? Dry powder inhaler over the meter dose inhaler. So DPIs deliver more drug to the lungs, about 20% of the total release compared to 1% for MDIs. Spacers are not necessary, they're not required or necessary with the DPIs. They are recommended for use with MDIs to increase the delivery of the drug to the lungs rather than oropharyngeal mucosa. DPIs do not require the hand-lung coordination, which is needed with MDIs. DPIs present no environmental hazard because no propellant is required for delivery. So the answer would be A, B, D, and E. So all but C. Bronchodilators. They provide symptomatic relief, but do not alter or change the underlying disease process, which is the inflammation. In almost all cases, patients taking bronchodilators should be taking also, they should be taking the glucocorticoid steroid for long-term suppression of the inflammation. So the steroids or glucocorticoids, they will take care of the inflammatory process and the inflammation. So the beta-2 adrenergic agonists, most effective drugs for relief of acute bronchospasm and prevention of exercise-induced bronchospasm. So relief of acute bronchospasm and prevention of exercise-induced bronchospasm. They activate the beta-2 receptors in bronchial smooth muscle that will result in bronchodilation. Very few cardiac side effects compared to the older non-selective beta adrenergic drugs. And that will range also in terms of the classification of the beta agonist, range from the ultra short to long-acting agonist. So we have a short-acting adrenergic agonist, SABA, and long-acting adrenergic agonist, which is called LABA. SABA versus LABA. Used in asthma, both quick relief, which is the short-acting agents, to treat to terminate the acute asthmatic attack. And these are called rescue agents, rescue medications for asthma, rescue asthmatic drugs. The onset for these short-acting, the SABA, within the onset within minutes, and it may last to up to 6 hours. Long-term control, long-acting agents. So the short-acting agents for the acute attack and long-acting agents for long-term use. It lasts up to 12 hours, should not be used as immunotherapy for asthma drug, and it should not also be used as treatment for acute asthmatic attack. It's just should be used as maintenance drug long-term, and so that will reduce the frequency of the asthmatic attacks. So a prototype drug for the beta agonist is albuterol. Albuterol is a bronchodilator, inhalation drug, as a drug of choice to terminate the acute bronchospasm due to asthmatic attack. It prevents also the exercise-induced bronchospasm for 2 to 3 hours if inhaled 15 to 30 minutes prior to the exercise. So it should be taken prior to anticipated exercise, about 15 to 30 minutes, which will last for about 2 to 3 hours from the onset of action. It's a safe drug during pregnancy. And we have different types of albuterol. We have inhalation, we have a tablet, we have solutions. So there are different formulas or forms of the drug. The PO form of albuterol, which is the Vospire, ER, which is the oral form of the albuterol tablet, immediate release and extended release step of Vospire, but it's not suitable for acute asthmatic attack. So the albuterol, it's the short-acting beta agonist, it's SABA, that is used to relieve the bronchospasm of asthma. Its rapid onset and excellent safety profile have made the inhaled albuterol as the preferred drug for the termination of the acute bronchospasm for asthmatic patients. And in addition to relieving the bronchospasm, the drug facilitates mucus drainage and can inhibit the release of the inflammatory chemicals from the mast cells. The Vospire, the oral form of albuterol, which is Vospire, we said had include the immediate release and extended release tablets. And also there is an oral solution of the Vospire. The oral forms have a longer onset of action. And again, we said it's not suitable for the acute or to terminate the acute asthmatic attack. The drug works as a beta agonist. So it will activate the beta 2 receptors in smooth muscle of lungs or bronchial. So will promote the bronchodilation and thereby will relieve the bronchospasm. So this drug is selective beta 2 adrenergic agonist because they activate only beta 2 receptors. So this has replaced the older non-selective agents. Like in the past, we had epinephrine, the isoprel or isoproterenol. This one is more safest kind of because it's more selective to the beta 2 receptors. The old medications, non-selective, used to be producing more cardiac effects, and there are non-selective agents that will activate alpha and beta as well. So these are more safest drugs than the old like epinephrine and isoprel. The adverse effects of albuterol. So we have both inhaled and the oral preparations. The inhaled, most of the so serious adverse effects from the inhaled albuterol are uncommon, but some patients experience palpitations, headache, throat irritation, tremors, nervousness, restlessness, tachycardia. Um, the oral preparations will produce also similar symptoms, side effects, in addition to also angina, um, dry mouth, chest pain. Now, caution in patients with a history of tachyarrhythmias or with hypertension and coronary artery disease, because this drug activate the beta 2 receptor. So the contraindications using because the albuterol may exhibit cardiovascular events in some patients, so we have to use the drug with caution in patients, as we said, with history of cardiac disease or hypertension or coronary artery disease. The drug may interact with the monoamine oxidase inhibitors or tricyclic antidepressants, and that will result in or cause the hypertensive crises and may increase the risk for tachycardia and angina. So it should be avoided within 14 days of beginning the bronchodilators. Concurrent use with beta blockers will inhibit the bronchodilation effect of the albuterol. So patient should also avoid this MAO and the TCAs as well within 14 days of beginning the therapy. So these drugs should be avoided within 14 days of beginning bronchodilators. Rinse patient and family education. We have to educate the patient and family that the patient on these medications should rinse the mouth with water and spit out. So it's going to gargle and spit out. So swish and spit. um, the to rinse them out um, after inhaling the drug to avoid swallowing the medicine or the medication that is deposited in the mouth, so we can prevent thrush or stomatitis, which is a fungal infection. Examples are drugs similar to albuterol. We have three very common drugs. The first one is the levoalbuterol, Zobinex, which is a short-acting Sisaba, salmeterol, which is the Servant, which is the LABA, long-acting, and the last one is terbutaline or Brethen, which is a short-acting, it's a SABA. So oral beta-2 agonists are used only for long-term control. Or formulations vary. The long-acting, the LABA, and oral preparations are used for long-term control, and whereas the short-acting beta-2, which is the SABA, are used for acute episodes. So this slide shows um, the importance of using the spacer for the inhalant drug. Inhaled, the second group of drugs is the anticholinergic drug, the inhalation therapy, um, inhaled anticholinergics. And the inhaled anticholinergic drugs are used for prevention or to prevent the bronchospasm. Occasionally used as alternative to beta agonist in asthma therapy, and it's used in the inhalation form. It causes bronchoconstriction by blocking the cholinergic receptors in bronchial smooth muscle, and which will result in a bronchodilation. Primary use, relief of acute bronchospasm, sometimes combined with beta agonist or glucocorticoid steroids. Also prescribed for chronic bronchitis and symptomatic relief of nasal congestion, because it will result in dryness. It's an anticholinergic drug, so it can be effective to treat symptomatic nasal congestion. The first type of drug for the anticholinergic inhalants is the ipratropium, Atrovan. So the primary role of the Atrovan or ipratropium is as an alternative to the short-acting beta agonist, and for patients experiencing severe asthma exacerbations, it is sometimes combined with beta agonists or corticosteroids to avoid additive bronchodilation. So the drug blocks the parasympathetic nervous system and result in effects similar to those of stimulating the CNS. So their actions are similar to those of beta adrenergic agonist, and it's sometimes combined with beta adrenergic agonist or steroids to provide additive bronchodilation. The inhalation form compared to the nasal spray form. The inhalation form provide effectiveness within minutes. The peak effect within like 1 to 2 hours, and the duration of effect will go up to 6 hours. However, the nasal spray form will provide symptomatic relief of rhinorrhea associated with common cold or perennial rhinitis. It inhibits the nasal secretions, but not the decongestant action. It will inhibit the nasal secretion. So it can be used as a decongestant. However, it will inhibit the nasal secretion. The ipratropium or Atrovent So as we said that the nasal spray formula of the ipratropium is approved for the symptomatic relief of runny nose associated with the common cold or allergic rhinitis. The drug inhibits nasal secretions, but it doesn't have the congestant action. Treatment is limited to 3 weeks. So for the ipratropium, the Atrovent, wait about 2 to 3 minutes between dosages. Avoid the drug to have contact with eyes, otherwise result in blurred vision. The intranasal administration may cause epistaxis and excessive dryness of the nasal mucosa, and epistaxis, which is nosebleed. This is one of the very common drugs, inhalation drugs, called Spirivia, tiotropium. And this is the device that we use to crack or open the capsule, and in which the patient will take the drug or would be administered to the patient through the mouth as a DPI, because that will convert from the capsule to open up the powder through when you close the the lip or the cover, that will open the capsule, and then the patient will be able to take the puff as a DPI. Questions? This is about a patient with COPD. However, this is about the Spiriva medication. So given that this is a anticholinergic drug, the Spirivia, tiotropium, Spiriva is an anticholinergic medication. So we anticipate that there is a mouth dryness or dry mouth or xerotomia that will result from the drug. So the answer is B. So Spiriva is an anticholinergic medication used to treat bronchospasm associated with COPD. The most common adverse effect is dry mouth. Patients can suck on hard candy for symptomatic relief. No need. It's not required. It's not necessary to take antacid medication, and use of a daily stool softener or wear protective clothing when taking the drug is not unnecessary or not required. Second question, it's about the short-acting SABA drug, albuterol, patient with acute severe exacerbation of the asthma. So which drug should the nurse anticipate to include in the treatment plan? The answer is D, high dose albuterol Proventil via nebulizer treatment. So nebulized high dose short acting beta agonists such as albuterol are administered to relieve airflow obstruction. The oral theophylline is used for maintenance therapy of acute stable asthma, not for treatment of exacerbation. Xolair is a second-line agent indicated for allergy-related asthma and only can be used when preferred options have failed. The corticosteroids, the inhaled corticosteroids such as mometasone, furoate, which is Asmanix, are not used to abort an acute attack. So during an exacerbation, they are administered systematically. Systemic administration is required when there is an exacerbation of the asthmatic attack. Medications that can be administered systemically, not the locally or any other route. Atrovent, contraindications, precautions, patients with hypersensitivity to soy lecithin or related food products such as soybean and peanut, and that's because the rationale behind this is that the soy lecithin is used as a propellant in the inhaler. Drug-drug interaction used with other drugs in this class, such as atropine, may lead to additive anticholinergic side effect, and the drug should not be so the patient and family education. We do not use Atrovent to terminate the acute attack of asthma. Wait 1 to 2 minutes between puffs before inhaling the second medication. So after inhaling the drug, rinse the mouth with water and spit out the water. Rationale: prevent systemic symptoms and eliminate bitter aftertaste. Before we go to the theophylline, just talk us briefly about why is there a different propellant in meter dose inhalers? The meter dose inhalants, the MDIs, was developed back in the 1950s, and the propellant used in the MDIs until recently contained a chemical called chlorofluorocarbones. And you may find when the MDIs were replaced that the different propellant is used in the inhaler, that this chemical is a propellant. What they found is that these propellant, just a concept here is that, these propellant, they found that these are they deplete the ozone layer high above the earth, and their protocol now was enacted worldwide to reduce the amount of this chemical to decrease the ozone depletion. So that's why there is a different propellant in the middle dose inhalers. Theophylline is a group of bronchodilators also that treat asthma. It's related to caffeine. Theophylline, it's an example of the methylxanthines, which used to be the once historically the mainstay of chronic asthma pharmacotherapy. However, because of its narrow margin of safety, and it will interact also its interaction with numerous too many medications or drugs. That's why its use become very limited compared to the past use. It's a natural substance found in small amounts of tea. The benefits of the drug derived primarily from the fact that it's a bronchodilation. So it results in a bronchodilation. It's not recommended for acute or to treat acute bronchospasm because short-acting beta agonists are more effective. So off-label use, respiratory stimulant, theophylline plus caffeine to treat sleep apnea in neonates and adults. So the theophylline has a narrow therapeutic index, and the plasma level treatment, therapeutic plasma level, therapeutic level should be between 5 to up to 15. The adverse effects are unlikely to occur until the level is over 20. So transient adverse effects usually will occur when the level above 20. So it's unlikely to be present. These adverse effects unlikely to be present at levels less than 20. Toxicity is related to theophylline over 20 micrograms per ml. Adverse effects, nausea, vomiting, headache, irritability, insomnia, dysrhythmia, in which that you can treat it with lidocaine, hypotension, seizures, and you can treat that with diazepam. Contraindications, precautions. So caution in patients with seizures, patients with CHF or dysrhythmias, highly metabolized by the CYP450 enzyme system. In other words, that the antibiotics like the Cipro, clarithromycin, erythromycin, benzodiazepines, and others will increase theophylline levels. So if patient has been diagnosed, being prescribed antibiotics to be taken concurrently with the theophylline, remember that the fluoroquinolones antibiotics like levofloxacin, ciprofloxacin, Cipro, or levo, um Levaquin. These antibiotics, fluoroquinolones, they will increase theophylline levels. So the dose of theophylline may need to be reduced to prevent theophylline toxicity. So we have so the nursing actions um, or responsibilities while taking care of the patient with on theophylline is that we have to monitor the for plasma levels of theophylline. So we need a frequent check on the plasma levels of theophylline, monitor the liver function tests, report any signs of toxicity like decreased appetite, nausea, vomiting, dizziness, restlessness, hypotension, or seizures. Patients should take the medication at the same time every day as prescribed. So I'm still on theophylline. I just flipped the page or this slide. I was still on theophylline. And we don't have, there is one drug just similar to the theophylline. The drug that is similar to the theophylline is aminophylline. Aminophylline. Um, Again, the use of the theophylline, aminophylline is very limited, given that um, the very effective short-acting and long-acting beta agonist drugs, which have the selective um, activity at the beta receptors, which means will result in less side effects. Now, corticosteroids. Inhaled corticosteroids are the most effective drugs for long-term control of asthmatic attacks. It's an anti-inflammatory agent, act by reducing inflammation. It's one of the foundation of the asthma therapy. Should be taken daily for long-term control and reducing the frequency of the attacks. And the principal anti-inflammatory drugs are the glucocorticoids. So the inhaled corticosteroids are the drug of choice to prevent asthma attacks and to manage chronic asthma. The short-term management should be limited therapy for under 10 days, which is usually given during the asthma exacerbation episodes. So it should be limited to under 10 days. With a tapering off activity in terms of that you have, when we prescribe it for 10 days, should be tapered off prescription, decreasing the dosage frequency until it's eventually being discontinued. So the corticosteroids, they are considered the most effective anti-asthma drug available, administered by inhalation, IV or PO. Symptoms will improve in the first week or by the second week of therapy, the symptoms will improve. First or second week. 4 to 8 weeks may be required for maximum effect. The PO prednisone usually prescribed for about 5 days, of max of 10 days. The primary use is to decrease frequency of asthma attacks. Also, this drug or corticosteroids can be prescribed also for the allergic rhinitis. So it should not be used to terminate the asthmatic attack in progress. It's used for chronic. So it will reduce the frequency of asthma attacks. In other words, for long-term use. So not long-term use, but at least to the PO to be prescribed for short-term use. But the drug itself should not be used to terminate the asthma attack in progress. So the systemic corticosteroids are reserved for short-term management of acute attack because of the detrimental effects of or side effects of the drug. So I have the aerosol inhalation, POVAR or piconase is the nasal spray. So the one for the to treat the asthma is the QVAR, the aerosol inhalation. However, the one that we can use for allergic rhinitis, that's the nasal spray, that's the piconase AQ. And it suppresses the inflammation. It decreases synthesis and release of inflammatory mediators. It will decrease the inflammation and activity of the inflammatory cells. It will decrease edema of the airway mucosa. So it's preferred drug for long-term management of asthma. Administered 2 to 3 times daily. The optimum benefit, it takes about 3 to 4 weeks for QVAR. But again, we said that the symptoms will improve within the first or the second week, but it may take longer for more maximum effect to be present. So the piclomethasone, which is anti-inflammatory drug for asthma and allergic rhinitis, it's an inhaled drug or corticosteroid. The intranasal piclomethasone is effective in reducing the symptoms of allergic rhinitis, and it's also approved to prevent reoccurrence of nasal polyps following the surgical removal of these polyps. Inhaled piclomethasone produce few systemic adverse effects because small amounts may be swallowed with each dose. The patient should be observed for signs of steroid toxicity, like hoarseness, dry mouth, change in taste, Inhaled corticosteroid use has been associated with the development of cataract in adults. The long-term intranasal or the inhaled corticosteroid may also cause growth inhibition in children. So the adverse effects can be severe when used long-term. So as with all corticosteroids, the anti-inflammatory features of piclomethasone can mask signs of infection. The steroids mask signs of infection. So the drug is contraindicated if an active infection is present. A significant percentage of patients who take the piclomethasone on a long-term use or long-term basis, they develop the oropharyngeal candidiasis, fungal oropharyngeal fungal infections, fungal infection in the throat due to the constant deposition of the drug in the throat or oral cavity. So the contraindications, so do not take this drug to terminate an acute asthma attack. The contraindications is contraindicating those for patients or with hypersensitivity to the drug. The growth also, remember that the growth of pediatric patients should be monitored carefully because the inhaled corticosteroid may reduce growth velocity in some patients, children cases. So the significance of that about the drug is contraindicated in patients with active infections is that because it masks the signs of infection. So the changes what we anticipate during the infection, like even the pus drainage or the exudates and the temperature change and all these symptoms of infection would be masked and not present during the infection due to the use of steroids. So in other words, that the patient with infection from mild or infection could result, the progress, uh, progress to develop a severe infection and septicemia without showing signs of infection. Because again, the drug will mask the signs of infection. Similar drugs to piclomethasone as the budesonide, which is Balmicor, fluticasone, which is a Flovent, and triamcinolone, which is Asthmacor. These are the three most common drugs similar to the piclomethasone. First question, which ask about which outcome should the nurse establish as a priority for patient taking oral corticosteroid for long-term treatment of asthma. And the answer for this one would be C. Adrenal suppression can be profound with oral corticosteroid use. So it is the priority that patient take supplemental oral or IV intravenous doses at time of stress. Failure to do so can be fatal, can result in death. because of the Edison's disease, severe adrenal insufficiency. So alternate day dosing, usual, or to use a peak flow meter, minimize bone loss, which is because the steroids, they affect the bone density and they can lead to osteoporosis. So minimizing the bone loss with vitamin D and calcium intake are important. However, they are not as important as supplemental doses of glucocorticoid at times of stress. The second question about glucocorticoid medication and the MDIs, or as a form of MDI, taken as an MDI. The answer to this one is C, which is about the spacers or spacer devices. Now, the spacers are available for use with MDIs to prevent the patient from swallowing the dose and to allow for maximum delivery of the medication to the lungs. Now, rinsing the mouth after administration is important for inhaled corticosteroid to prevent candidiasis and fungal infections. Corticosteroid inhalers are used for long-term prophylaxis of asthma, not for symptomatic relief. When 2 puffs are needed, an interval of at least 1 minute should separate the first puff from the second. Inhaling through the mouth just before activating the MDI is the proper technique. Next question. To achieve therapeutic effectiveness, nurse teaches a patient with chronic asthma to use an inhaled corticosteroid medication according to which schedule. That should be on a continuing daily basis. Corticosteroid medications are the first line therapy for asthma to reduce symptoms of inflammation. They should be taken for prophylaxis on a daily basis. Therapeutic effects develop slowly, so these drugs cannot be taken to abort an asthma attack or in an emergency. They are most effective when administered on a fixed schedule, not as on a PRN schedule. Which instruction should be included in the teaching for patients for whom fluticasone Flovent MDI has been ordered? Gargle after using your inhaler. A is the correct answer. Patient should be taught to gargle and rinse the mouth after using inhaled corticosteroids, such as fluticasone, to minimize dysphonia and oropharyngeal candidiasis. The medication is not used, this med is not used to abort an acute attack. Short-acting bronchodilators such as albuterol should be administered 5 minutes before inhaled corticosteroid. So if that case, in cases that patients should receive both medications, so the albuterol, the bronchodilator, should be administered 5 minutes before inhaled corticosteroid. So bronchodilator, albuterol, and then 5 minutes wait, and then take the corticosteroid to enhance delivery to the bronchial tree. For more effectiveness of the albuterol or of the drug, that should be taken 5 minutes after, should be administered 5 minutes before inhaled corticosteroid. So bronchodilator, 5 minutes wait, and then glucocorticoid or steroid inhalant. Oral corticosteroids, it will put the patient at risk for hyperglycemia. As one of the very common side effects of steroids. Now, this question about the aminophylline, which is diethiophylline methylxanthin drug. So the dosing for aminophylline is based on each patient's serum theophylline levels. The loading dose usually is 6 milligrams per kilogram. And after that, the maintenance infusion is titrated according to the theophylline levels. And this is the reasons why, another reason why, these drugs became not widely used as, compared to the past. A serum theophylline levels of 15 is within therapeutic range. So we will skip this question. Now look at trend modifiers. This is a new class of drugs for asthma treatment, not used for acute asthma attacks. It suppresses the effects of leukotrienes, less effective than inhaled corticosteroids or glucocorticoids. Oral medications used when persistent asthma not controlled with other medications. So the Montelukast or Singulair, it's a drug that prevents airway edema and inflammation by blocking the leukotriene receptors in the airways. So leukotrienes are the mediators of the immune response. Which is the same mechanism that is involved in the allergic and asthmatic reactions. So it relieves edema, inflammation, and bronchoconstriction. Leukotrienes primarily, or leukotriene modifiers, primarily used for asthma prophylaxis. It will reduce the inflammatory component of asthma. The drug is available in chewable tablets as well as the granules that are recommended by the manufacturer to be mixed with like an applesauce, or ice cream. So we do not use this drug to terminate the acute asthma attacks. If preventing exercise-induced bronchospasm, it should be taken. The drug should, take the drug at least 2 hours before the activity or anticipated activity. The drug produces few serious adverse effects. Most common is headache, nausea, and diarrhea are reported by some patients. The only contraindication is hypersensitivity to the drug. Given the fact that because of few rare cases of hepatic failure have been reported in patients who have taken or been taking the singular, those with pre-existing hepatic impairment should be treated with caution. So we have drugs similar to the singular, like Zephyr-Lucast, Aculate, which is used for prophylaxis of persistent chronic asthma, and it's only available as PO tablet. Most common side effects, same thing, headache, and same thing also in terms of contraindication. It's prescribed with caution for patients with hepatic impairment. So nurses teaching a patient about Montelukast singular, which statement by the patient would indicate that the nurse's teaching was effective. So the answer is B. Montelukast is an anti-leukotriene drug or agent. So combining Montelukast with an inhaled glucocorticoid medication can improve asthma. And reduce the symptoms, and it may allow for reduction in the corticosteroid dosage. So the effect of the singular develop slowly, so it cannot be used as a quick relief agent. Short-acting beta-2 agonists are preferred for exercise-induced asthma. Singular does not affect coagulation, so bleeding and bruising do not occur. And usually the Montelukast or singular is given as an adjunct to inhaled corticosteroid to help prevent inflammation. Some patients sometimes report mood changes when taking this drug. So parents should be warned of the mood changes effect as a side effect from this drug, if that's given to children or uh, young adults. The medication is given once daily, and usually the dosage for like a 7-year-old child would be like 5 milligrams daily. Adults may take up to the 10 milligrams daily. Mast cell stabilizers. So the mast cell stabilizers are used for the prophylaxis of asthma by preventing the release of histamine. So they are safe for prophylaxis of asthma, less effective than inhaled corticosteroid, less effective than inhaled corticosteroid, and ineffective at relieving the acute bronchospasm. Won't be effective. Cromolyn is the prototype drug for mast cell stabilizers, used as an alternative drug for treating the mild to moderate asthma when corticosteroids are contraindicated or haven't proven effective. And it should not be given to terminate acute asthmatic attack. So cromolyn is used for prophylaxis, not quick relief, not for acute attack, suppress inflammation, not a bronchodilator. It's effective in exercise-induced asthma when used 10 to 20 minutes before exercise. So the adverse effects of the cromolyn is the safest of all anti-asthmatic asthma medications. Cough, bronchospasm can be one of the side effects or adverse effects. Takes up to from 2 to 4 weeks for the drug to achieve the maximal therapeutic effect. So using albuterol with cromolyn, use bronchodilator albuterol first, and then 5 minutes wait, then take cromolyn. Next drug is the Xolair, which is the first biologic therapy approved to treat asthma. The drug attached to the receptor on the IgE, decreasing circulating free IgE levels, and prevent the IgE from attacking the mast cell, the mast attached to the mast cell, to prevent the release of the chemical mediators, including the histamine, leukotrienes, cytokines, and others. And usually the Xolair is given every 2 or 4 weeks. Currently, this drug is under clinical trials. Now we have a combination drugs like glucocorticoid LABA, like the fluticasone, salmeterol, Advair, discuss or Advair discuss, different concentrations. That's why you see two numbers, 250/50, which includes both medications. Patient who takes cromolyn for exercise-induced bronchospasm should follow which approach for maximum therapeutic effectiveness. So it should be administered by inhalation 15 minutes before anticipated exertion. Cromolyn suppresses the inflammation through inhibition of histamine release. So it must be administered at least 15 minutes before exertion to prevent exercise-induced bronchospasm. It is administered by inhalation only. It is not the bronchodilator and cannot abort an ongoing attack. It is one of the fastest antihistamine, anti-asthma drugs or medications, very fast and has no systemic adverse effects. No COPD. Chronic obstructive pulmonary disease, COPD, commonly caused by chronic bronchitis or asthma, is progressive and end-stage emphysema. So the patient with COPD, they either have emphysema or chronic bronchitis. So the COPD is characterized by presence of airflow obstruction. Again, it's caused by emphysema or chronic bronchitis, very progressive disease, maybe accompanied by airway hyperreactivity, and maybe partially reversible. Fourth leading cause of death in the U.S., more than half of COPD patients die within 10 days, 10 years of diagnosis. Now exposure to tobacco smoke still being the primary cause of COPD in the U.S. Now diagnosing patients with COPD is very challenging because we have to follow the guidelines, which states that the presence of chronic productive cough for 3 or more months in each of 2 successive years in a patient whom other causes of chronic cough have been excluded. So we have to be careful with all of these conditions to diagnose patients, to finally diagnose patients with COPD. Because it has to be presence of chronic productive cough for 3 or more months in each of 2 successive years in a patient whom other causes of chronic cough have been excluded. So this slide presents the significance and detrimental effects of cigarette smoking and tobacco exposure, and how it's dangerous for for the lungs and all these pathophysiological changes that could or physiological chemicals that are included in the tobacco and that may lead to COPD. Infection, major contributing factor for the aggravation and progression of COPD. Recurring infections impair normal defense mechanisms. Hereditary. So the alpha antitrypsin deficiency, it's linked or some type of correlation with the COPD. What they found is that AAT deficiency is the only known genetic abnormality that leads to COPD. AAT deficiency accounts for less than 1% of COPD in the US. AAT, we know it's the alpha antitrypsin. It's the enzyme that is produced by the liver and normally found in the lungs, may lead to premature emphysema, that deficiency of the enzyme. So emphysema results in the lysis of lung tissue, So see, patients with COPD, the shape of the rib cage becomes more rounded like a barrel chest, and that's would result in a decreased compliance, reduced compliance of the chest wall, and increased work of breathing. Two different types of emphysema, centrilobular and panlobular. Centrilobular, which is central part of lobule, walls are destroyed, bronchioles uh, become abnormal, like confluent, or like flowing or running together, blending into one, the bronchioles. And this often is associated with the chronic bronchitis more than with emphysema. And this type of centrilobular is more common than panlobular. However, the panlobular, which is the destruction of the whole lobule, affects bronchioles, alveolar ducts and sacs, alveoli, progressive loss of the lung tissue, decreased alveolar capillary surface area, unusually found in persons with the alpha antitrypsin deficiency. So emphysema, the destruction of alveolar tissue will lead to inflammation, exudate formation, and to edema and swelling of the mucosa of the alveolar tissue. The elastin and collagen are destroyed, which results in no pull or traction on the walls or the bronchioles. In other words, it results in stiffness and decreased elasticity of the bronchial uh, increase or decrease of the lumen. Air goes into the lungs, but it's unable to come out on its own and remains inside the lungs. This causes or lead to bronchioles to collapse. And the third change would be the trapped air, which is the hyperinflation and over distension of the alveoli. So more alveoli collapse, blebs and bullae may develop. The blebs are the air sacs adjacent to pleurae. So the figure shows the bullae and the blebs. So the gas exchange abnormalities result in hypoxemia and hypercarbia, which is an increased CO2 as the disease worsens. So as the air trapping worsens and alveoli destroyed, the bullae, which is the large air sacs into the lung tissue, and the blebs, which is the air spaces adjacent to pleurae, can form. And both are not effective in gas exchange as the capillary bed that normally surrounds each alveolus does not exist in the bullae or bleb. Therefore, there is significant VQ mismatch and hypoxemia result. So this is one of the advanced mechanisms how the VQ ratio, VQ mismatch and hypoxemia would be the end result of this pathophysiological change in patients with emphysema. So the hypoxemia usually it develops late in disease, and the compensation is done by increasing respiratory rate to increase alveolar ventilation. However, with the chronic bronchitis, even though the emphysema and chronic bronchitis, they are both will be categorized under the COPD, the chronic bronchitis, there is a hyperplasia of mucus secreting glands in the trachea and bronchi. So there's an increased excessive secretions, thick mucus secretions from the inflammation. So frequently the airways are colonized with microorganisms because there is an excessive amount of mucus that are found and may occlude small bronchioles. Cough is not is often ineffective to remove secretions because the person cannot breathe deeply enough to cause airflow distal to the secretions. So cough is not effective in removing or mobilizing the secretions from the pulmonary tree or bronchioles. So patients with COPD, especially asthma or chronic bronchitis, they would have dyspnea. First, at the beginning, patients will first complain of dyspnea and exertion, and then progress to that dyspnea will interfere with the ADLs at rest. Minimal coughing with no small amount of sputum, over distension of alveoli will cause the diaphragm to flatten and the AP diameter to increase, anterior posterior diameter to increase. So patient become chest breathers, relying complete on their accessory muscles for respiration. Then they will develop something called retractions. The ribs become fixed and inspiratory position. Patient become underweight, even when the patient adequate calories intake is sufficient. So patient will develop protein calorie malnutrition with loss of lean body mass or muscle mass and subcu fat. So in diagnosing patients with COPD, typical finding include reduced FEV, FVC, which is FEV, which is forced expiratory volume. And this ratio is important because the ratio of less than 70% suggests presence of the obstructive lung disease. Now, treatment or drugs for patients with COPD. So the first drug, the group of drugs, medications will be bronchodilators to decrease airway resistance and hyperinflation, reduction in dyspnea, and increase in forced expiratory volume, given as maintenance therapy, and the beta agonist nebulizer or metered dose inhalers that it's the preferred route of administration, and the long-acting beta agonists are preferred over the short-acting for COPD. Although the theophylline methylxanthin was once standard therapy for in patients, COPD patients, it is no longer recommended. So it is used only if beta agonists are not available. So long-acting beta agonists are preferred over the short-acting for COPD. Inhaled anticholinergics, they have minimal side effects and best if taken on a regular basis. Other therapeutic modalities will be the oxygen, the vapotherm. I just included here a YouTube video to explain about the vapotherm modality, and then in which that they deliver flows or oxygen flows of warm, humidified air through the nasal cannula or a transtracheal cannula. Combination drugs like the ipratropium and albuterol combined in one drug called Combivent is used to treat the COPD. The Combivent is more popular than other beta agonist anticholinergic combinations. The most common drug of this type of combination is Combivent. The usual dose is 1 puff or inflation. 1 puff inhaled 4 times a day. So if the patient takes this puff as an inhalation therapy for 4 times daily, 4 times daily, sometimes patients need more puffs to be inhaled as needed, but they shouldn't exceeding the 10 puffs in the 24 hours. The question here, history of allergy to which substance is the contraindication to the use of Combivent. Now the answer is peanuts. So the patients with peanut allergy should avoid Combivent, which contains soy or soya lecithin as a carrier. Soya is the same plant family as the peanut, And about 10% of people with peanut allergy are cross-allergic to soy. Allergy to the remainder of the options is not the contraindication. And this concludes the recorded lecture.